Good afternoon, everyone. I shall be presenting my experience on the intravitreal clindamycin in cases of the presumed Toxoplasma chorioretinitis. I don't have any financial disclosures. You know that the Toxoplasma gondii is the intracellular parasite which is the most common cause of posterior uveitis in the world, anywhere. And the various types of presentations you can see, there are so lots of collections of this Toxoplasma chorioretinitis in my practice, which were healed congenital toxoplasmosis as well as the active toxoplasmosis. Today's basic purpose of presenting is to report to off-label intravitreal clindamycin plus dexamethasone in a chorioretinitis cases. We have started it 7 years back with the few literature support, and to our surprise we have got lots of good results, and we will see in our cases. But what is the conventional treatment and what is the new treatment? Before that, we should know that how we are treating the Toxoplasma with the Bactrim DS2 loading doses, and then 1 BID for 3 weeks to 4 weeks. Same time, in few cases we were adding clindamycin as well as the systemic steroids and topical steroids and cycloplegics. But why we have considered intravitreal clindamycin and dexamethasone combination in Toxoplasma? Because exclusively it is an isolated local pathology in most of the cases. Intravitreal injection bypasses the blood retinal barrier, so the most of the drug is available for its action. It's high drug concentration at the target site. No systemic side effects of various drugs, which we know that the steroids are also having side effects. Sulfa drugs is also having, and clindamycin also has its own side effects, and they are very highly toxic. There is no wastage of time till the drug resistance is detected. Most of the time drug resistance is also detected in cases. In cases of pregnancy particularly, there is no contraindication because we are giving very small dose, and that too in an intravitreal cavity. It is mostly cost effective. The drug cost is very less and effective also, and it is also ideal in immunocompromised patients who are already taking so many drugs. So the method was that the dose was 1 to 1.5 milligram of clindamycin along with the dexamethasone 4 milligram at the interval of 4 to 5 days because of the half-life of the clindamycin, and 3 to 4 injections of 4 days interval were enough in all our cases. The primary outcome measure was there were changes in the Snell's visual acuity as well as the resolution of inflammation and the adverse effect if at all. So the results were the injections of intravitreal clindamycin was associated with control of toxoplasmic chorioretinitis and resolution of vitreous inflammation in all our 14 cases. All patients had improved in visual acuity. In 5 patients, vision was limited because of macula scarring, or the lesions was very close to the macula. There were no adverse reactions or complications and no need of any vitreoretinal surgery. This was the first case. You can see that this was the active Toxoplasma lesion, and after injection it is completely resolved. And this is second case, 40 years male patient. You can see that typical fog in the light case, and it has completely resolved. Then this is another case which was reactivated Toxoplasma in an immunocompromised patient, and it also resolved very well. This was just juxtafoveal macular reactivation of the Toxoplasma, and after 4 injections it has completely resolved. This is again a Toxoplasma lesion in a case 5, 20-year-old male patient, and after 4 injections it is completely resolved. This was another case, case number 6, 60-year-old male patient has suffered a Toxoplasma retinitis. Basically, it was not a choroiditis, and you can see that it is completely resolved. This is again a reactivation of the Toxoplasma lesion which was very close to the fovea, and after resolution you can see the complete resolution after only intravitreal injections. This is in a papillomacular bundle lesion of Toxoplasma chorioretinitis, and it is resolved completely. This was again in juxtafoveal reactivation of the chorioretinitis, and this black color is a old lesion, and it is completely resolved. This was a case number 10. We can see that there is a large reactivation of the chorioretinitis with the subretinal fluid also, but with the injections it has been resolved completely. And this is in case number 11. You can see that the fog in the dark light, and this again resolved, and to the safer side because of the recurrences we have done the laser to this lesion also. This was a 38-year-old patient who was having papillitis, juxtapapillary chorioretinitis, as well as the phlebitis case. And you can see on the angiography also papillitis and phlebitis. On OCT you can see the retinal thickening and port, and after the 4 injections it is completely resolved, and there is no papillitis now, there is no phlebitis also. This was a doctor patient, a 32-year-old male. He was having juxtafoveal or just subfoveal chorioretinitis. You can see on the FAF also, and after 4 injections it has been resolved. And on OCT also it was showing the retinitis lesion. This is the last case, which was a 19-year-old female. It was a reactivation of the old papillomacular bundle chorioretinitis as well as the papillitis, and you can see there was a phlebitis also, and which we don't have the post-op picture of this patient, but it resolved completely with the injections only. All these 14 cases, there were so many also, but we don't have the records of each and everyone. But in my practice, I have seen that this is a very novel approach of giving only intravitreal clindamycin and dexamethasone, which has reduced the cost also, and the toxicity and the compliance of the patient also. And with the 3-4 injections, you get the good results. That is how the intravitreal clindamycin injection alone was associated with resolution of toxoplasmic chorioretinitis in our 14 cases. Thank you very much.